Thank you. Hello, good morning, everyone. First, I just want to apologize for the slight delay. The commissioner is currently tied up in a cabinet meeting. Hopefully she can join us soon, but we want to, in respect of everyone's time, we want to go ahead and get started. So I'd like to just begin by welcoming everyone to the 6th public meeting of the Network Adequacy Work Group that was convened to consider revisions to the MIA's 2017 regulations that establish standards for the sufficiency of carrier provider networks. I'd like to start by going over just a few housekeeping procedures for the day. First, this virtual hearing is being held via the Zoom webinar platform and is being recorded. The video and sound recording will be made available on the MIA's website within the next few days. Second, only those individuals who received a panelist invitation and who have accessed this meeting through that link can be seen or heard. In addition to the commissioner, myself, and several other MIA staff members, links were sent to individuals who requested to speak in advance. If you fall into that category, but you've not been able to log in, please let us know via the chat feature, or if you're on the phone line, I'm sorry, Craig, do we have an email address we can put up on the screen for those to email if they have questions? Also, even if you did not sign up to speak, if you do wish to be heard, please let us know via the chat function, and we can then call on you in turn and unmute your line and allow you to speak. Also, to help ensure good sound quality throughout the meeting, we ask that you please stay on mute unless you are speaking. So with me on this call from the MIA are several of our staff. Hopefully the commissioner should be joining us shortly. But right now it's myself, David Cooney, I'm the Associate Commissioner for Life and Health here at the MIA. We also have Erica Bailey, the Associate Commissioner for Compliance and Enforcement. Mary Quay, the Chief of Life and Health Complaints. Karen Lamb, Chief of Health Insurance and Managed Care. Emily Schrift, who is one of our Assistant Attorneys General here. Lisa Larson, who is a Director of Hearings and Regulations. Paul Meyer, who is a Special Projects Analyst for Life and Health. And then Craig Guy, our Communications Director. So at our last meeting we had here back in December, before we temporarily suspended these hearings during the legislative session, we provided an overview of the MIA's objectives and rationale for these draft revisions. And those revisions were posted to the MIA website on November 4th. We also heard from stakeholders who wish to expound or elaborate on any of the written comments that they had previously provided for specific sections of the draft regulations. So the plan for this meeting here today is to continue going through the regulation section by section and give all stakeholders an opportunity to present their comments and suggestions for our consideration before we move forward with formally proposing the revisions. And I'd like to note that, as I mentioned, we received written comments. There were a lot of written comments we received. We spent a lot of time reviewing those comments. We met internally here at the MIA to discuss them and consider where we might be able to incorporate them into the regulations. We also, started drafting some of those revisions where we thought it was appropriate. So we spent a lot of time there, and the purpose of this meeting isn't really to just have stakeholders rehash everything they put in writing, because we've already considered that. But the purpose here is really more to just allow stakeholders to be able to highlight some of the most important points that they thought they had, and also to provide any new information, thoughts, or insights that you may have had based on developments that occurred since the last time you submitted public comments. Also, since all the public comments were up there on our website, if any stakeholders want to respond to written comments from other stakeholders to offer a different perspective, we'd love to hear that today. Excuse me. And at our next meeting, which has already been scheduled for June 18th, we plan to finish the section by section review if we don't get through it all today. But that meeting will primarily focus on the role of telehealth and network adequacy, and it will give particular consideration to Senate Bill 3, Chapter 71 from the recently concluded 2021 legislative session. So while telehealth may come up as a topic today, we do request that stakeholders defer any in-depth discussion of telehealth until the next public meeting, since that will be the primary focus there. And with that, I think we can jump right into the agenda. So where we left off at the last meeting was Regulation 05 in the proposed draft, which is the revisions to the travel distance standards. And just a brief overview of what the draft regulations did in that section is primarily we standardized the methodology for measuring and reporting travel distance metrics. We also included several new travel distance standards for new categories of mental health and substance use disorder providers specifically. That was an area where we've had a lot of requests for that over the years, and it just will allow us to have more insight into where network gaps may be with respect to mental health and substance abuse. So we felt that was very important. Along those same lines, we revised the essential community provider inclusion standards to include specific information for mental health and substance use disorder services. And we also standardized the methodology for calculating the essential community provider standard. And that new methodology is based on, well, it isn't just based on, it essentially adopts the Maryland Health Benefit Exchange methodology for calculating ECPs. So with that, I would like to open it up to any panelists on the call. And actually, before we do that, I see the commissioner is joining right now. So Kathleen, thank you for joining. We just ran through the housekeeping and we're just about to jump into the first set of regulations.
No, you keep going, David. Thank you. I apologize to everybody for being late, but I had a matter that I had to attend to. So David, please.
Sure. So yeah, as I was saying, we can open it up now to anyone who has any comments they would like to provide on the travel distance standards in Regulation 05. So panelists can feel free to unmute themselves if they would like to speak. Okay, so there are, I'll just mention if no one has anything specific to bring up now, there were a couple things in the public comments that I'll just address briefly. One of the things that we added to the travel distance standards was just a request for carriers to include information on any kind of analysis they did on areas where a significant percentage of the population uses public transportation, and how they basically took that into account when they're looking at travel distance for their enrollees. Based on the comments, there seemed to be a lot of confusion that the MIA was perhaps establishing a new standard in that area, and that is not what the draft actually proposed. It is more along the lines of, we feel this is an important issue. The draft proposal doesn't establish a standard there, but it basically wants to know what are carriers doing to address this issue. If you're not doing anything at the moment, then that would be a response, and that might, prompt further follow-up questions from us. But the regulation doesn't necessarily require anything to be done other than report how you are addressing this issue. There were also several comments that seemed to be some confusion over the outpatient infusion chemotherapy metric. This was a particular metric for travel distance where a lot of carriers said it was just very difficult to measure because the category we had chosen in the regulation, it wasn't really a set category of providers where consumers went to that particular provider to get the service, but there were a lot of different providers that could provide that service and it was difficult to measure. So I do want to clarify there that in the draft, we define that term and we deliberately define it very broadly to allow a carrier to include basically any setting or provider who is authorized to provide those services can be included in that category going forward. So with those comments, before we move on to the next section, just want to give everyone one more chance if you did any comments on the travel distance standard section.
Good morning. This is Dr. Sabi. Can you hear me?
Yes, we can. Thank you, Dr. Sabi.
Awesome. Thank you, everyone. Thank you for this opportunity to just share some comments. I am Fazi Sabi. I'm an OBGYN with the Mid-Atlantic Permanente Medical Group, and I'm also the Associate Medical Director overseeing our network and contracting. We wanted to just share background around our group practice model, where we have over 200 OBGYNs, and over 100 of those OBGYNs serve members in the state of Maryland. In our practice model, we have panels for all of our patients, and for our female patients, all of our women can choose both a primary care physician and an OBGYN with whom they are on a panel. In this panel model, we care for women from adolescence through reproductive health through menopause. And so our OBGYNs see both pregnant and non-pregnant patients in the clinic as part of their panels. Therefore, we don't have a gynecology only designation for our OBGYNs.
You're on mute, David.
Thank you, Craig. Dr. Sabi, I was just acknowledging your comment in that I'm assuming you're speaking to the fact that the current regulations have one category for a combined GYN OB provider and a separate GYN only category, which basically establishes, two standards. And it's a situation where providers in either standard could technically be providing those GYN only services. Is that what you're getting at there?
That's right. Thank you.
Sure. Thank you.
David, this is Ellen Weber. I just wanted to take the opportunity to thank you for this hearing again, and to also just identify, as you had requested, just sort of some of our priorities in the area of network adequacy, in the area of travel distance. Obviously, you have our comments, and I'm not going to repeat them. But among the key priorities are, we appreciate the greater granularity for substance use disorder providers. These are providers that are providing services in Maryland, and we think that it's appropriate, given the gaps, to fully understand how many of these providers are within carrier networks. I think it will help us all understand what the problems are, and so we appreciate that granularity. We also think that it is absolutely essential, in order to have the separate ECP requirement, the 30% requirement for substance use disorder essential community providers, the 30% for mental health, and the 30% for others. Without that, if you just have it a blanket 30%, there really is little chance that a mental health or a substance use disorder specific provider would be included as a result of that requirement. There is somebody on the phone who is an essential community provider for substance use services, and at some point I would really like to have him explain some of the problems that he, as an opioid treatment program, has had getting into into a network. And I think that will identify why this criteria is so important, and why I think it will increase the likelihood that substance use programs are in networks. There has been a proposal, and I know this relates to telehealth, and so we will, again, speak to it next meeting. But we did take a look at the 10% credit that has now been just very, very recently put into place under Medicare Advantage plans. This was not something that's been in existence for a long time. It's not even been tested. It has just been put into place. We would oppose that use of a 10% credit, either for both the distance and the wait time. As we know, Medicare Advantage only has distance requirements, but it also has some minimal standards for numbers of providers for certain types of providers. But also in Medicare Advantage, and this again touches on our key interest in telehealth, Medicare Advantage also protects patients who want to have in-person services as opposed to telehealth services. And there are regulations that protect that were also taken into consideration when this 10% credit was adopted. And so again, it does not really eliminate the need for having sufficient numbers of providers that can be available in person within a reasonable time and distance as set out in the regulations. So we oppose the adoption of that type of a strategy. Unfortunately, what we think it does is, in fact, it just, again, further masks what the problems are, not to take it as a pejorative term, but to, in fact, sort of paper over some of the problems, as well as giving us really the opportunity to identify where the real source is, which has not yet happened. So those are our key priorities with regard to appointment wait time. We also firmly agree that it's important to identify by zip code where there are gaps, rather than having it in sort of just those very broad geographical areas. Getting that level of detail by zip code, we think is quite important, and will help illuminate issues. Thank you.
All right, thank you, Ellen. And as you said, we can certainly go into a lot more depth about telehealth at the next meeting. So I look forward to those conversations. And you mentioned an ECP provider on the phone.
That is me, yes.
So you're on right now. Oh, that's great. Would you like?
Absolutely. So no, I'm not on the phone. I'm actually on the computer. Good morning, everyone. Thank you for the opportunity to speak. My name is Dr. Emmanuel. I'm the owner of two methadone programs, also known as opioid treatment programs. My programs are classified under community-based substance use disorder programs. We serve predominantly low-income individuals. As such, we are classified as an essential community provider. I support the MIS proposed essential community provider standard for the following reason. Currently, there are 3 opioid treatment programs in Carroll County. 2 are in Westminster and 1 is in Eldersburg. Care First Network does not have an OTP in Carroll County. As a matter of fact, none of the commercial insurance networks have an OTP in Carroll County. There's a significant need for our services at Carroll County and Baltimore City. On average, we'll fill about half a dozen calls a week from patients asking if we take Care First, Aetna, or other commercial insurance. We tell such patients that they would need to pay out of pocket and then would file a claim with our insurer for reimbursement, with understanding that there are no guarantees that their commercial insurance would reimburse them. Many of our patients do have commercial insurance and pay out of pocket. We really do not keep track as to how many of our cash patients really have commercial insurance. We have tried to get paneled with Care First. After months of paperwork and credentialing, we received our contract and noticed that the reimbursement was about 50% or less of the cost of the services that we were required to provide based on state and federal standards. I will provide you with 4 examples here. Example number 1, the initial drug and alcohol assessment is reimbursed at $158.26 by Medicaid and $179.46 by Medicare. Care First offered us a reimbursement of $98. For patients being treated with buprenorphine, also known as...
I'm sorry, doctor, could I just interrupt you for a second? Would you, I couldn't write fast enough. Would you give me those numbers again?
Absolutely. So the initial alcohol and drug assessment, that's the assessment that we do at the very first visit. Medicaid pays us $158.26. Medicare pays us $179.46. Care First offered us $98 exact. Example number 2, for patients being treated with buprenorphine, also known as Suboxone, Medicare's bundled weekly reimbursement is $258.47. Medicaid allows for billing and reimbursement for medication in addition to the professional component. Care First offered us $80. We brought it to their attention and informed that the wholesale cost of the medication alone would be as high as $140 a week. The response was take it or leave it. Example number 3, we are required to provide counseling to our patients. This is a state and federal requirement. Medicaid reimburses us $22.29 for each unit of counseling. A unit is about 15 minutes of counseling. Care First contract did not provide any reimbursement at all for counseling. Example number 4, Medicare and Medicaid both have provisions for periodic medical provider evaluation. Medicaid's reimbursement rate is anywhere from $23 to $147. Medicare has a flat rate of $110. Care First contract did not provide any reimbursement for such a service. We exchanged about a dozen or so emails with Care First regarding the above concerns. At each and every attempt, the response essentially was take it or leave it. Care First refused to negotiate a fair rate. Again, I'm here to urge you to support the MIS Essential Community Provider Standard. The Essential Community Provider Standard will force the commercial carriers to contract with 30% of the substance use disorder essential community providers. This requirement will force them to negotiate a fair rate. Short of that, they will not agree to a fair rate and patients will suffer. I also would like to talk about Section D if possible, or should I leave it for another time?
Section, excuse me, section D, you said?
Correct.
Is that still with the travel? I'm sorry, I'm not sure which section you're talking about. I mean, you can certainly get to it now. We may be getting to it later, but if you want to
Sure, I would go on. Section D talks about changing from a waiver request to require filing for failure to meet standards. My understanding is that this change in regulation would require commercial insurers to report on their efforts to contract with providers. In our case, CareFirst and all the other commercial insurers have made absolutely no effort to contract with us. If I had to guess, this is the case with all the other opiate treatment programs. So such change in regulation would require carriers to report the reasons provider gave for refusing to contract. I believe it is essential for the MIA to understand why the substance use disorder providers are not joining the commercial carriers network. Substance use disorder providers are very much interested in joining, but they are not given a fair reimbursement rate. And that's all I have. I would be happy to take any questions.
Doctor, one question that I have is just to give me the full context. Have there been circumstances where you or your treatment center have been asked to enter into a single case agreement?
To enter into what agreement?
A certain circumstance where you enter into a contract just to treat one particular patient?
No,
Okay.
we have not.
All right, thank you.
Sure, thanks.
I'd say I just have one other question for either you, doctor, or for Ellen. This was a comment the Legal Action Center had made with respect to we had included one of the new categories that we had for distance was drug and alcohol treatment program in general. Ellen, you had suggested that should be specific to opioid treatment program. And I wanted to mention that the reason we chose the category that we did was based on our research into the actual health department regulations. So if you believe the opioid treatment program is more appropriate as a separate standard, if you could point us to any Department of Health regulations or otherwise exactly where that program is, that would be helpful to us.
Yeah, we'll take a look at that, David. One of the reasons there seemed to be some redundancy in the various categories, and so we wanted to eliminate the redundancy.
Sure.
And then, put a sharp focus on opioid treatment programs, again, because of some historical problems in bringing those in, just as Dr. Emanuel has mentioned.
All right, thank you. Okay, would any other stakeholders like to speak on the travel distance before we move on to the next section? Okay, so the next section of the regulation is Regulation 06, which is for appointment waiting time standards. This is certainly, in my opinion, at least the most challenging section, the most challenging metric that we've been working with so far. Well, one of the things that we felt was most important was to standardize the methodology that carriers would use to measure this standard so that we could get more consistent information from carriers that both we as the regulators and consumers could more effectively compare one carrier to another. So just broadly, what the draft revisions do here is they establish new quarterly monitoring of wait time performance instead of a snapshot at one point in time in the whole year, and also quarterly reporting of the median wait times to enrollees. We also expanded the categories of appointment types that must be measured. Along the same lines of the travel distance, it was primarily to have more granularity for mental health and substance use disorder services. And then we proposed a standardized methodology both for measuring and reporting the appointment wait time metrics based on a combination of consumer surveys and direct contacts with providers. Finally, acknowledging the challenges there are with wait times and the challenges that the valid challenges there are on the carrier side, and the fact that we were expanding to include additional standards for appointment wait time. We also proposed to reduce the threshold that would actually trigger regulatory action from 95% of enrollees meeting the standard down to 90%. So those are kind of overall what we propose to change here. And again, I would just like to open it up to any stakeholders who would like to, expound on any of their comments or bring any new insights on this issue here. So again, if you're a panelist, feel free to unmute yourself. If you're not a panelist, just let us know in the chat function that you would like to speak. Okay, if, oh,
David,
go ahead, Ellen.
you know, the
Yes.
only, again, I hate to hear nothing. Silence is problematic. You know, again, you have our comments on this. I mean, you know, again, in looking at the I guess this is more of a question than anything else. In lowering the threshold from 95 to 90%, I mean, part of the complexity here is sort of what our goal is. And I think our goal really is to try to get adequate networks and to figure out where the problems are, and so that we can have targeted solutions to that. And so and again, the other components are all fitting in together here in terms of, again, how we use telehealth, you know, and what those standards are going to be. So the resolution of that also, I think, has a direct effect on what your threshold is here. But the other component is, you know, because over the past 3 years, the MIA really has not taken strong enforcement actions against carriers that have not complied with these standards. And not knowing, again, what your plans are for the future on this, lowering the standard from 95 to 90, again, doesn't have measurable impact on the carriers because they're not being penalized for not complying. But it does have a huge impact on consumers and members, because if they are not held to a high standard, and if they aren't required to report why they're not meeting that standard, then we're never going to get to the bottom of where the problems are and to what the solutions are. And so again, my sense and I think all of our goal is to get to adequate networks. And so I would rather be able to see, you know, are you hitting this mark? And if you're not hitting this mark, then you have to report out why you are not satisfying these standards and what your efforts have been. And I think changing that waiver request to a requirement to present your demonstrating what you do is going to get us further along than almost anything else. But we don't want to lower the requirement for making that report out. So that to me is, you know, is what's critical here. We need to get to the reasons why you're not able to satisfy these metrics, almost as much as what that metric is. Hope that makes some sense.
Yes, thank you. I appreciate it.
David, this is Matt from the League of Life and Health Insurers. Thank you guys for all your proactive work on this, but I'm not going to rehash anything that I submitted in writing or the other carriers did, but I do want to just to say thank you to the MIA, and especially Karen, for reaching out about helping the carriers try to establish the universe of providers. We're not exactly sure the 100% best way to do it yet, but we really want to work with you. It will help us expand networks, and we are really appreciative of the outreach to us. It's a work in progress, and we're willing to be at the table, and we hope that this can be an avenue that will help us improve things. So thank you very much.
Thank you, Matt. And yes, as you mentioned, and for those others on the call, there's legislation that's been proposed 2 years ago that we were hopeful would help identify the universe of practicing providers. And unfortunately, it didn't really go very far. So we have just internally been looking into, with our existing resources and what we have, ways that we can help better identify what that universe is. And it's not going to be perfect, but we are working on something. and we'll certainly, communicate that once we have something in place there.
Lori, did you want to speak? There's a comment from Lori in the chat room.
Yes, I don't believe she was a panelist. So,
Unmute. Maybe Craig can unmute her.
right.
Seconds, unmute her.
Thanks, Craig.
Okay.
Hi, Commissioner. Hi, David. Good to see you both. Just that we're trying to gather more information, and we've spoken before about the credentialing issues, and thank the MIA for helping us work through some of these. And what we've heard so far is this is about a typical wait for someone who is commercially insured, trying to get an appointment in one of our outpatient clinics. And sometimes that's because there was a credentialed clinician in the clinic and that person left for whatever reason, and then we have to go through the process again of credentialing a new individual. There could be, numerous reasons for this, but that's basically what we're seeing so far in our survey data.
Thank you.
Thank you.
Okay, does anyone else want to speak? And I do appreciate like all the written comments. So, again, we have read all those. If people aren't speaking up, we still certainly considered all those comments, and we don't need to keep everyone here unnecessarily long on a holiday weekend, just rehashing those comments. But again, if anyone does want to speak up, please do so.
David, I'm sorry, Ellen Weber, one other question. I noticed something that was submitted again in the, in one of the carriers' comments, the Aetna comments. They identified an NCQA sampling that has apparently a lower standard than what's being proposed. Can that NCQA sampling be shared with the group? We don't have access to that. And in order to, to assess what the recommendation is, it would be very helpful to have that.
Thank you, Ellen. I actually had a note about that myself as well to bring up today. So we have not received follow-up on that item. So I had the same request as you. We would certainly consider that NCQA sampling methodology, but if that carrier could, provide that information, we would really appreciate that.
David,
Yes.
this is Kimberly from Cigna. Sorry, I'm not on camera this morning. The only thing I would add in an attempt not to rehash comments that you've received from the carrier community is just to emphasize that wait times, I think, is one of the measures with which you can see through the carrier responses we struggle with the most. It is certainly understandable why, and I can understand it just as a patient myself, why it's something that patients want to understand, and yet it is something fully within the knowledge base of providers in their offices. So unlike being able to run a geo access of my own members against my own provider directory where all that data is mine, I have to go out and ask providers and rely on providers to give me that information to turn it then into something I'm reporting back to the department. It is something that I think has historically had its pitfalls, even under the current regulation. And there's a reason why you see such a reaction to moving to the quarterly assessment when it comes to what it takes to get the assessment done at all, when it comes to getting those surveys back from providers, the extra work it means we're putting on providers to have to give us that information because we do not otherwise have any way to assess what's happening in their offices, how they're managing their time, what their capacity happens to be. I appreciate Matt raising that conversation around understanding the supply of providers, right? Because if you've got, and I know we hear a lot from Ms. Weber because she's focused in a particular practice, but this is for all practice specialties, right? So it's not just behavioral health that's subject to this particular provision, it's for all specialties. So if you've got a limited number of providers in the state in a particular specialty, and even if you have them all on your panel, they still only have a certain amount of capacity to see patients. And so those wait times do inform what a patient might experience, but it still may not be something that a carrier can do anything to change. And increasing the burden then on provider staff to have to constantly respond to quarterly reporting from every commercial carrier in the state at a certain volume is a concern. Because I'll be really candid. I think, putting words in my colleagues' mouths, I will say, I believe one of the things our provider relations staff hears the most of from providers who are participating is concern about increased burden of participation. And so, we do encourage the MIA to continue this conversation and perhaps have a more in-depth conversation with carriers about what the experience is like working with providers and what that looks like and what that turns into, because we don't want to make participation less attractive to any set of providers, because that's going to be antithesis to what we're trying to accomplish and trying to get them in the network. So thank you for the opportunity.
So Kim, I thank you for your remarks. And I think perhaps what we need to do is actually hear from providers directly. So I appreciate your perspective and what you hear from providers about not wanting to see additional paperwork be a barrier. And that can be overwhelming. But I think that perhaps what we need to hear from are providers and provider representatives about what kinds of reporting in this area would make sense and how we can get to a uniform approach. And I'd like to get input from them. So perhaps that needs to be, part of the outreach. So we're hearing directly from those people that you're concerned about burdening, what they would consider a burden and what they would consider reasonable. I don't know if you or the league have had that kind of conversation. That's not sort of, individualized as people, your credentialing, group talks about issues, but maybe what we really need to do is have that direct conversation.
And Commissioner, I really appreciate that thought. I think one of the challenges when it comes to wait times in particular, but some of the other things that often come up in this conversation around this regulation is certainly the fact that networks are a partnership between carriers and providers. And it's the nature of the way we regulate in the state that your purview is specifically on carriers. And I think it often lends itself to a conversation that doesn't bring providers in, except for those who have concerns and are coming forward, but as a larger community to the table as a broader stakeholder in the conversation, in a way where we're talking about some of these things where we are trying to, through the third party of the carrier, access provider information. And so I do think that would be helpful, particularly on wait times, because it would give, I think, all stakeholders a better understanding of what makes sense in this space, what questions are useful, how best even providers think that information is being assessed, what their experience is in terms of the variation in how wait times ebb and flow in their own offices. Only one of my colleagues happens to also have providers as part of their corporate structure. They've got a different insight than those of us who aren't owning provider groups. And so I appreciate your willingness to see how those conversations may be helpful to us all.
Yeah, absolutely. And we will convene, we'll talk to MedChi and some others and convene, a meeting with them. I have some pretty concrete ideas that aren't really quite ready for prime time in terms of how we might be able to gather this information in a simple way. But I don't run a medical practice. So I think your points are well taken in terms of what a medical practice can realistically do and what you can expect from medical practices. But let's hear what they say.
Thank you so much.
Commissioner Brain, this is Matt again, and I'd like to sort of echo the comments of Ms. Robinson. I think I've heard anecdotally from carriers that sometimes reaching out to providers to try to expand networks has been a frustrating experience at the very least. We have, and like talked about it earlier, but providers that don't update their information, they don't respond to the surveys. they've been contacted 3, 4, 5 times by phone call, by email, by fax in some instances, and they still don't respond. So if having MedChi involved in this discussion and having some providers, so to say, skin in the game, so to say, I think would certainly be helpful, and I think would help carriers be able to ultimately improve the networks as we've been all sort of striving for. So thanks for the opportunity.
I wanted to make sure that everybody was aware of, so both Senator Eckert and Senator Augustine are both with us today. And if you want to be unmuted so that you can comment at any time, please just let us know. We're happy to hear from you at every step of the way. But I definitely wanted to point out the senator's comments in the chat room, that hearing the experience from various providers, as there are barriers and the wait time is extensive from what I hear from citizens needing help and the limited providers. And that's a great project for the Professional Association and Provider. So thank you for those comments, Senator.
Okay, before we move on, I just wanted to mention one thing. This is along the lines of what Kim, Matt, and the commissioner have already been speaking to, but I do want to just highlight what the draft regulation actually does. I mean, because we are, with respect to the outreach to providers. So we definitely hear you guys that we don't want to increase the burden on providers. And certainly I think hearing directly from providers will be helpful to give us more insight into what is a burden. But what we've been hearing from carriers is this is going to be super burdensome on providers. They're going to have to answer these quarterly surveys from every single carrier, and you're not going to get responses. But to just find out what the wait time is for a service, if a consumer just picks up the phone and calls and says, I need this service, how long till I get an appointment? I mean, they're doing, the provider office is doing that every day. So I'm having a difficult time understanding why having some form of direct contact from a carrier to a provider asking essentially that same question is so much more burdensome than the calls they get every single day from consumers. So just keep that in mind. We definitely hear you on the burden issue, but show us how it's a burden, and we'll certainly be reaching out to the medical community on this issue as well.
David, just to
Yes.
that, just a little bit of insight on that. I think, well, one, we aren't in the habit of calling into our providers' offices as though we're patients. You know, we would have to call and identify ourselves. And we do call as one of the ways the surveys are often done. But it also takes up their time because we don't just call them and ask them how long before I can get an appointment. There's a number of different things that go into that assessment because we've got to ask them all those different questions for all those different wait time measures, right? So yeah, it's easy to say it's just a phone call. They typically know right away what it is. You know, I'm calling in as a new patient. How long before I can get an appointment? I'm an existing patient. What's the next available appointment? But we also have to be able to document it. There's a lot more that goes into that. And there's a reason why we survey them the way that we do. And we also have accreditation standards that we refer to, I believe in the Aetna letters, Ms. Weber pointed out to, for how we have to collect that data. So we're happy to have that conversation about what surveying providers in this space really practically looks like, that it's not just we kind of call them up like we're a patient and ask them the question, to just sort of reflect what it takes also with the volume of providers that has to be surveyed, what the investment looks like in terms of the cost to carriers to do it on various frequencies, right? Be it semi-annual, be it annual, being quarterly, and what that means is we're trying to also build out the network and run the network and run the plan. So I think that's another conversation we can have, and it might be easier to have that directly with individual carriers.
Absolutely, thank you, Kim. Hello, Senator Augustine, did you want to speak or are you just in for later?
I'm in to listen and learn, and just really, obviously, you know, grateful for this conversation. And this is just such an important topic, and I really am happy that you all are continuing this hard work and trying to improve the situation. Thank you so very much.
right, thank you. We appreciate your insight as always.
I think Senator Eckerd's hand is up, David.
Oh, I didn't see that. Yes. Hello, Senator Eckerd. Would you like to speak?
Well, thank you very much. I just hopped on for a little bit because I've been tagging as many of these as possible, and I'm finding it fascinating, and I think you're exactly on the right track, so thank you. I'm learning a lot, but I'm learning what we don't know that might be helpful in eliminating a lot of barriers. I was just hearing about this. I was out with our Haitian community, and we've been trying to get access to healthcare and appropriate providers. And again, the wait time, whether we're talking about kids services, whether we're talking about how we deal with trauma and prevent the violence. We've got an increase of violence, and a lot of that's getting people connected to the right clinicians at the right time. So looking at how those barriers are reduced is so very important. And I heard just this week that in the private insurance world, there's a wait time of 30 to 60 days. And that to me seems way too long to get follow-up for psych care in the community. Just seems way too long, because it's important when you're dealing with opiate addiction or mental illness. People have to be connected to a provider immediately to be able to help them transition from a hospital stay or an inpatient stay to the community. So whatever we can do to find out what are the logistics, what are the steps, how do we expedite those connections, what do we need? Do we need to clean up the list? Do we need to get the professional associations to help to get people to update their information? There have to be practical ways that we can address this going forward. So thank you very much.
Oh, thank you, Senator Eckhart. Okay, one last time, any more comments on appointment wait time standards before we move on to the next section?
Yeah, David, I'd like to chime back in, I guess. I appreciate all the comments that folks are making, and I also appreciate that there are wait times involved with some of these appointments, which is sort of frustrating, especially for consumers. But I also appreciate, David, that you said at the beginning of this conversation that this is the one with the most nuance and the hardest to pin down. And part of that reason is that some folks don't appreciate the difficulty of how we're trying to measure some of this. So for example, if you need a mental health service or you are in sort of crisis, if you call the behavioral health service hotline of Cigna or Care First or United or whomever, they will keep you on the phone until they get you an appointment that day. What the regulation is not taking account for is a lot of people say no. They don't want the appointment with the person that we can get them immediately. Now, there are all kinds of reasons for that, and a lot of them might be valid. But if I am a 28-year-old Asian woman who calls and says, Cigna says, I can get you an appointment today with Jim Smith, who is a 82-year-old white man in Towson, that might not be the most attractive thing for somebody that's looking for a behavioral health appointment. There might be more nuance. You might not be comfortable talking about that depending on your situation. So there are a lot of times that people say, no, that's not the appointment I want. Okay, that's fine. And we want to get you the appropriate service where you're most comfortable. But the regulation does not take into account the fact that there are carriers that are doing proactive things across the board to try to get you an appointment today. A lot of times it's just the consumers don't choose to take that option. So I'm not saying that means that the problem is taken away. I'm just saying taking the first available appointment isn't the same thing as taking the appointment in which you are desiring. A lot of this has to do with the pent up sort of things because of the pandemic too. People are re-entering the world now in a fashion they weren't and getting services. Look at the airlines. Look at what the pictures we're seeing for BWI in the last couple of days. We're seeing a volume that has increased like we haven't seen in over a year. It is the same thing as going on in doctors' offices across the state. People are going back out and re-engaging with their healthcare services like they hadn't done for a while. So I know this is a long-term thing, but we just need to continue to remember that there is nuance to every one of these conversations. Thank you.
Thank you, Matt. Okay, let's see. Ellen, I see you raising your hand.
I just have to respond. I'm sorry. I have to respond. This gap in and deficiency in covering mental health and substance use disorders has long preceded the pandemic. We have had years of demonstrated deficiencies and lack of compliance. And we've also seen years in which none of the carriers, except for one, has even requested a waiver of these standards. And the carrier that did request a waiver never answered any of the questions that is required in the regulations to get a waiver. So this is a long-term problem. It has been exacerbated by the pandemic, no question about it. But the carriers have not met their obligations for years.
Ellen, the pandemic comment is a broad one and wasn't specific to mental health. So just try not to take it out of context, please. It's frustrating.
So let me just say that I think we hear what everybody is saying here. And, Matt, your point is well taken about, whether you use mental health as an example or others as an example. There may be times when someone is looking for a particular physician or a particular practitioner or a particular area, and that is a nuanced view. And Ellen, I think we also understand and appreciate the frustration that so many people experience when specifically trying to access mental health services and substance use disorder services. And that is an area of particular concern within network adequacy. So, we hear you both and appreciate your professionalism in, identifying and addressing both of those issues. So we hear you, both of you.
Thank you.
Okay, I think we can now move on to the opposite spectrum of probably the least controversial of the metrics, which is the provider to enrollee ratio standards. This is Regulation 07. This was an item where we standardized the methodology for measuring it. I think it was pretty straightforward already, but we did just want to spell that out in the regulation as to how precisely this should be measured. We received very little comments on this particular section, but again, if anyone has anything they would like to comment on for the provider to enrollee ratio standards at this point, please speak up. Okay, we can move on. The next section is Regulation 08, which was the network adequacy waiver standards, which have been discussed a little bit already in different contexts of this meeting. But essentially, under the existing regulations, carriers could request a waiver of a standard if they failed to satisfy the standard. What we proposed is to change it from a request for a waiver to instead simply, if a carrier does not meet the standards, they're required to provide certain information as part of the access plan filing. And the commissioner will then consider all that information and determine whether or not to grant a waiver. But it's no longer optional to provide that information. If you don't meet the standard, the carrier is expected to provide that information. We also, in that information I'm speaking of, it's the information that was previously required as part of the waiver request. So all that information is still there. And we requested some additional data points that we'd like carriers to provide in these situations. Also, along with that, we proposed that if the commissioner does grant any waivers, those waivers that are granted by commissioner, that will be posted on the MIA website to indicate which carriers received the waiver for which specific standards. So we did receive some comments on that section. Again, we've considered them, but if any stakeholders would like to speak up now and highlight what's important to them or have any new insights, we would love to hear it. While I give all stakeholders another second, I will just respond to one of the comments that was received. Some of the additional information we now requested in the waiver section is essentially it already asked carriers, like, what outreach did you do to providers? Who did you contact? If you did, and they refused to contract with you, what was the reason given? Things along those lines. But what was missing before is really what is the carrier's expectation of how many new providers they would need to add to their network in order to achieve the standard. So in other words, if you give us a list of 100 providers and all sorts of different specialties that you reached out to, but you really needed, 10 additional providers in this one particular category, that list we were getting previously didn't really, give any insight there. So we modified that to specifically require the carriers to indicate, what analysis did they do to determine how many additional providers they would need to achieve the standard, and what that number is, so we can actually compare that to what their outreach efforts were. And we did receive some comments from carriers trying to tie this to the idea that the universe of practicing providers is unknown. And we've discussed that at length at various meetings, and we realize that's a problem. But that issue is not in any way related to here. You don't need to know what the universe is to know how many you need in your network to achieve the standard. And the way the universe of practicing providers ties into that is that's why the waiver request will be granted. If you show us we needed 20 providers in this specialty in order to achieve, and we know this particular specialty, we have everybody in our network, there's only 15 additional providers, that's the type of thing that would give the commissioner cause to grant a waiver. So I just wanted to clarify that. And are there any other comments on the waiver section? Okay, I think we can then move on to Regulation 09, which is the confidentiality provisions. This here was just a very basic clarifying change that was made to the draft proposal. The regulations indicate that the commissioner shall consider certain parts of the access plans to be confidential. And one of the items in the existing regulations was the methodology that carriers use to measure some of these standards. And what we wanted to acknowledge with this draft proposal is that we have now standardized a lot of that methodology, and the methodology items that we have standardized in the regulation, that should no longer be considered proprietary confidential. But we also wanted to acknowledge that there's still certain aspects of the methodology that will be carrier specific and may be proprietary. So it was just a minor revision to the language to clarify that the proprietary methodology may still be confidential, but anything basically that we've standardized in the regulations, a carrier cannot request that to be confidential. So are there any comments on that section there? Go ahead, Ellen.
My only comment, and we didn't comment on this extensively because we've done so in previous years. And one of the, as you know, there is a proviso in that confidentiality provision that references back to the state provision on the Mental Health Parity and Addiction Equity Act. Under federal law, it is clear that carriers cannot withhold information regarding the way they have developed their plan and all of the processes, the standards, the strategies. They cannot withhold that information based on a claim of proprietary information. Federal law is crystal clear on that. And so this provision has always referenced back to our state incorporation of the Parity Act standards. And so I just want to put a pin in there to say that too has to be taken into consideration when considering a carrier's request for confidentiality. If it relates to the way the network, if there's a challenge with regard to the way the network is established for purposes of a mental health or a substance use provider, then there is no protection for that information. That is not protected as confidential information. It must be disclosed. And so just wanted to identify that and make sure that that we, have brought that up in the context of this most recent process.
Sure, thank you, Ellen. And as you said, that provision is still in the draft proposal regulation. Okay, any other comments on that section before we move on? Okay, well, we are moving right along today, which is great. So the last section of the regulation that we propose revisions to is Regulation 10, which is the executive summary form requirements. So the current regulations specify the information that has to be reported on the executive summary, which is a public document, and no part of that can be treated as proprietary, confidential by the carriers. And they are posted to the MIA website every year once we receive the access plans. And it's primarily intended as a overall summary that consumers and other stakeholders can look at and try to compare, performance year to year and from carrier to carrier on the various standards. So although the information is standardized among carriers, we have not previously developed a standardized form so that it actually looks the same when we get it from all the different carriers. So the draft proposal does propose that. It will not be, the standard form would not be specified in the regulation, but we would do that via our website after getting, soliciting comments from stakeholders. And the other revisions to the executive summary section are primarily just to conform to earlier changes that were proposed for the actual standards themselves in the regulation. So for example, where we had more granularity for mental health and substance use in the actual standard itself, the executive summary now has to have that additional granularity. So that was what we were working to do with this section of the regulation. And were there any comments or questions about that? And while people are thinking, I will just acknowledge the comment from Deb Rivkin from Care First. And we appreciate that, Deb, that we received a lot of substantial comments from Care First in writing. She indicated there's nothing particularly new to bring up at the moment, but I do expect to provide additional comments in response to some of the commentary at this meeting.
David, the only thing I wanted to raise is we do think it's very important to have local health departments identified as whether they're participating, what services that they are providing. And again, I know that there's a recommendation that this may not be available on the credentialing form, but nonetheless, it's critically important information and should be easily enough of it. It should be able to get that information easily enough.
Yes, thank you, Ellen. And I will address that issue. That comment, I think we received multiple comments on issues such as that, saying that that information was difficult for the carriers to obtain. I do want to just kind of explain our position on that item. There is, if it's not easy to get it, that is regrettable. And we do want to find ways to help carriers get that information more readily. But just the fact that that's not available so easily is not really a compelling argument to us, because carriers are offering contracts that are promising particular benefits and also promising that if you go to an in-network provider, you'll get better cost sharing and be protected from balance billing. So it is incumbent on the carriers to be able to identify the providers in their own networks that can provide these particular services. So that is our expectation that, if a consumer needs a particular type of service from a health department, the carrier should be able to tell that consumer whether or not that particular provider only offers, medical services, or whether they also provide services for mental health or substance abuse.
David, hi, it's Debbie. Based on that statement, so this is something new that I want to bring up as opposed to previously. One of the things we offered as a solution, as opposed to just saying no to things, was looking at the uniform credentialing form and seeing if there could be other data points that could help carriers collect this information. And that is one of them. I think that we thought was difficult at this time, is because if it's in your scope of practice, you have the right to do it, to provide that service. We have to pay for it, and the state recognizes your right to actually provide it. So to get to the level that you want, to know what their providers are actually providing versus their licensure, would be really one way to look at that is through the uniform credentialing form and see if we could add additional information. And we also noted in a number of other places in the reg where we thought it could be helpful also to get additional information. And I was just wondering if you've thought about that as a potential solution so we can try to move this forward a little bit.
Sure. Thank you, Deb. It is something we are thinking about. We're still mulling that over. We do see some challenges with that, but we are certainly considering it and looking at it, and we're happy to have more in-depth conversations on that topic specifically going forward.
Thank you.
Okay, well, that was the last section that we had on the agenda for today. We can go, one last time around if there's any comments on the regulation in general that someone didn't bring up previously, they would like to bring up now. Again, reminding everyone that telehealth will be the focus of the next meeting. So you can certainly, hold off your comments specific to telehealth until our next meeting. But otherwise, one last time around, does anyone have any comments they would like to offer today? Okay, thank you. Oh, wait, I see a comment in the chat. Give me 1 second. So the question was if we can speak to timeframes and process on finalizing the regulations. Unfortunately, I can't speak specifically to that right now. I mean, I certainly personally want to finalize these as soon as possible to get the new ones in place, but there is still a lot of disagreement on a lot of these items, and we're still working through some of that. We have to make decisions as to whether we will do another draft before a formal proposal, or whether, as a result of these meetings here and the comments we received, if we'll go straight to formal proposals. So I don't have a lot more details right now, unless, Commissioner, if you have kind of your goals that you'd like to speak to or anything.
No, I think that's right, David. This rigorous conversation has been really helpful, and it's also shown us some areas where we need some additional data, including, for example, today's discussion about what do we need to hear from providers. So we're going to try to push this through. We have the June meeting that's coming, and I know internally we really sort of like to get this wrapped up by the end of the year in terms of having regulations done. I think that's the best I can give you. But every time we get into this, there are things where we realize we need to consider a few other data points, but we are not going to allow the perfect to be the enemy of the good. So we are going to move forward, and I expect that we will have revised regulations by in September. After we've had all the other meetings, including the provider discussion that we'll set up. But to David's point, we haven't decided yet whether we're going to repost them and do one more round of comments informally on our website, or whether we'll just go straight to a formal proposal. And I just want to thank everybody for the robust conversation. I know people are very passionate about their views, but that's very helpful to hear the detail and to hear people's points of view. So I want to thank everybody who was able to contribute today.
Okay, Commissioner, do you want to say any more comments in the wrap up, or I think, are we all good now?
I'm good.
Okay, well, thanks everyone, as the Commissioner said. And I will just, as a reminder, this meeting has been recorded and it will be posted to my website in the coming days. And we certainly look forward to seeing all of you on June 18th. And I hope everyone enjoys the nice long holiday weekend.
Take care. Be well. Thank you, everybody.
Thank you.